Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Today we are going to be talking about patterns of lung disease, abnormalities of the secondary pulmonary lobule. Let's start off with some essential anatomy. So the secondary pulmonary lobule is the elemental unit of lung function, and each secondary pulmonary lobule contains a central artery, which is aptly named the centrilobular artery, and a central bronchus, each branching many times to ultimately produce a sinus arteries and respiratory bronchioles. On CT, the centrilobular artery is seen as a very faint dot, but the centrilobular bronchus is not usually seen. Then we have within the secondary pulmonary lobule multiple acini, which are considered the basic unit of gas exchange. Within this acinus, we have multiple generations of branching respiratory bronchioles, alveolar ducts, and alveoli. There are generally about 12 or even fewer acini per secondary pulmonary bronchiole. Then, if you look at the periphery of the secondary pulmonary bronchiole, you can see that the pulmonary vein is in the periphery, and then the lymphatics are also found in the periphery of the secondary pulmonary lobule. This information is very important, as we'll come and see later. So let's take note of that in the periphery of the secondary pulmonary lobule, that's where we have the pulmonary vein and the lymphatics. Then some connective tissues called the interlobular septa encase each secondary pulmonary lobule. So you can see something gray around it here, and encases that. So this would be what we call the interlobular septa. Thickening of the interlobular septa can be seen on CT, and it would suggest some pathological enlargement of either the venous or the lymphatic spaces, as we know that they are the structures that are in the peripheries. Each secondary pulmonary lobule is between 1 and 2.5 centimeters in diameter. Okay, so now we'll talk about some abnormalities of the secondary pulmonary lobule, starting with consolidation. Consolidation is histologically defined as complete filling of the alveoli. We know that the alveolus is supposed to contain air, right? So if anything apart from air is found inside the alveoli, it would cause consolidation. And so if you have blood in there, you would have what we would call pulmonary hemorrhage. If you have pus in there, it could be a pneumonia. If you have water in there, it could be from a pulmonary edema. If you have cells in there, it could be some cancer proliferating, filling the alveolus. Okay, so that's how you think about the differentials of consolidation. What could be filling the alveolar space? Then when you have consolidation as well, because the density is going to be similar to the vasculature, you would have the pulmonary vessels being obscured. And when the bronchi and the terminal bronchioles, in fact, when the airway is still patent, you would have these lucencies, these linear lucencies within the opacification, what we would call air bronchograms. They represent the still patent bronchioles and bronchi within the consolidation. Consolidation also causes what we call silhouetting of adjacent structures. In a radiograph, we are able to see two different structures because of the differences in their densities. And so if they have different densities, we can see a line between them at their interface. However, if they have the same density and they are standing side by side, we'll not be able to tell where one ends and where the other one begins. So that's what we call silhouetting. So in this image, the CT image, we have this is a contrast enhanced CT, and it shows bilateral consolidative processes. See one here and then one here on the left and on the right. It's more densely consolidated here on the left. There are also bilateral air bronchograms. You see these air lucencies, these lucencies, linear lucencies within the consolidation. Here you can see multiple air bronchograms within it. Now, although these findings are non-specific, it could be anything filling the alveoli here. It could be blood, it could be pus, it could be water, it could be cells. But this actually was a case of multifocal consolidative adenocarcinoma. Then to ground glass opacification. Now, histologically, ground glass opacification, similar to consolidation, is filling of the alveolar, but this time around it is partial filling of the alveolar. So the same things that will fill the alveolar that will cause consolidation can also cause ground glass opacification if the filling is partial. So partial filling with blood, partial filling with pus, partial filling with water, partial filling with cells would all cause ground glass opacification. So then the differential list can also come from this. When you have the walls of the alveolar also being thickened, you may have ground glass opacification because you have air plus thickened alveolar walls. When you have reduced aeration, you also have ground glass opacification because the air is reduced, and in relation to the solid parts of the lung, and would also cause ground glass opacification. Now, the term ground glass opacification is reserved for CT, not radiographs. We shouldn't use the word ground glass opacification on radiograph, but on CT you can use the word ground glass opacification, and what you see is a hazy gauze-like opacity where the pulmonary vessels are still seen within the opacity, unlike consolidation where the pulmonary vasculature is obscured. In ground glass opacities, the pulmonary vasculature is still seen, but then there's still this hazy gauze-like opacity in the lung, and it's said to be a precursor to consolidation because the same things that would eventually totally fill the lungs can partially fill the lungs. But then if you have chronic protracted ground glass opacification, there are certain differentials that we can entertain that are different from what we would see in the case of acute ground glass opacification. Differentials for chronic ground glass opacification include lung adenocarcinoma, organizing pneumonia, chronic eosinophilic pneumonia, interstitial lung disease, hypersensitivity pneumonitis, among others. So in this CT image, we see diffuse ground glass opacification. The pulmonary architecture, including vasculature and bronchi, can still be seen, which is characteristic for ground glass opacification. Although these imaging findings are non-specific, this was a case of acute respiratory distress syndrome. Then we have peripheral ground glass opacification. So when you have the opacifications just being peripheral, some of the differentials you can entertain include organizing pneumonia, chronic eosinophilic pneumonia, and pulmonary infarction. So in this axial CT, we see peripheral and subpleural ground glass attenuation, and this was a case of organizing pneumonia. Then we also have another pattern of disease called interlobular septal thickening. So you remember we mentioned that the interlobular septa contains the pulmonary veins and the lymphatics. So any condition that will dilate the pulmonary veins, like congestive cardiac failure, pulmonary edema, will cause smooth thickening of the interlobular septa. So in this CT image, we see smooth thickening of the interlobular septa demonstrated by these yellow arrows, and this was a case of pulmonary edema. Conversely, when you have irregular nodular interlobular septal thickening, it could be a matter of certain metastatic deposits within the lymphatics, and we know that the lymphatics are in the periphery of the interlobular septa. So that would be a case of lymphangitic carcinomatosis, which is actually quite rare, but is usually one of the very first differentials that you should think of when you see nodular or irregular interlobular septal thickening. Sarcoidosis also causes nodular thickening of the interlobular septa, so it's also another differential to entertain. So in this axial CT, we see diffuse nodular septal thickening evidenced by the yellow arrows, and this was a case of lymphangitic carcinomatosis. Finally, we'll talk about crazy paving pattern of disease. Now, crazy paving pattern of disease is basically what we have discussed in the past put together. So ground glass opacification plus interlobular septal thickening. Now, this is a very non-specific finding, but it was first described in alveolar proteinosis, where you have proteinaceous material deposited within the alveolar space and also within the interlobular septa. So you have the septal thickening plus ground glass opacification. But this is just one differential out of many. You can have pulmonary edema being a cause, you can have pulmonary hemorrhage being a cause. It's a long list of differentials. Let's just know that this pattern is non-specific, but if you are pushed to the wall and you have to give one differential, you can mention alveolar proteinosis or pulmonary edema, right? So in this axial CT, we see interlobular septal thickening. Once you can see multiple septi, yeah, thickened septi all around. And still within the area, you can see that the pulmonary vasculature, the pulmonary parenchyma appears to have this gauze-like hazy opacity with air bronchograms. There is some more denser consolidation more posteriorly, but up here is where you see the ground glass opacity plus the interlobular septal thickening. And this actually was a case of alveolar proteinosis, the entity in which crazy paving was first described. The next thing we'll talk about is approach to multiple micro nodules. Thank you very much. I'll see you in the next lesson.